what is global health or define it. And there's a kind of classic set of definitions now, again, about 10 years old from Copeland, who says, global health, first and foremost, is a set of problems, right? It describes health issues and threats that transcend boundaries, right? That it's not public health. It requires this international collaboration. Therefore, when we practice global health, it's something interdisciplinary, it's something collaborative, there's something fundamentally already requiring a multi-sectoral approach because of the nature of the kinds of problems that it's seeking to confront. And third, it also speaks to a kind of aspiration, right? Global health is what we want. We want health for everyone. And that as part of that kind of norm or that moral commitment, global health means about kind of reducing inequities and achieving, and this is, I think, an interesting, and you hear this more, justice in health research and healthcare. Now, what does this mean or look like? There's these classic, Mauricio, I'm blushing since you have such a more robust definition of what equity is, but these kind of nice schematics of thinking, what is the difference between equality, equity, and justice, right? So equality, everyone benefits from the same, everyone gets the same. Equity, to each person according to their needs, right? And then justice is actually, we're fundamentally removing the structural issues in the first place and going to the kind of cause. Now, what's interesting about this question of how we think about causes and how it brings us to justice in the context of global health, I put a quote here from the late Paul Farmer, which I think is a nice way of thinking about and why social science is important in kind of exploring how global health thinks about its problems. And he writes, the just and equitable distribution of the risk of suffering and of tools to lessen or prevent it is too often the unaddressed problem in global health. No one sets out to ignore equity, but the way we frame issues of causality and response typically fails to give them due consideration. So I think what's really interesting is this question of how we frame, the problem, right? How we think about what kind of problem is this, precipitates the kinds of solutions that we have available or thinking about the solution. So, is this a problem of mental health or is this a problem of poverty, right? Those will trigger very different sets of conversations. Is it both? How do we think about the way we, at least at the start, put a kind of a definitional space about what the problem is. I mean, the other kind of interesting set of conversations that have been happening, and particularly, post-COVID, is, part of the issue is who does the framing of the problems, like who decides what these problems are and how we act upon them. And there is, I'm sure you are aware, a kind of burgeoning literature around how one thinks about decolonizing global health. And I think, we can think about, and it's an, question about whether or not that's the right kind of language we want to use and what does it mean to decolonize. But the gist being that there is a history of global health, right? In this piece, they're saying, global health has evolved from colonial and tropical medicine. There's a legacy which were designed to control colonized populations and make political and economic exploitation by European and North American powers easier. The operations of many organizations active in global health thus perpetuate the very power imbalances they claim to rectify through colonial extractive attitudes and policies and practices that concentrate resources, expertise, data, and branding within a high-income country, with high-income country institutions. And I mean, this is not pulling its punches, but the argument being that even by the way, structurally, global health is set up as allocating northern resources out there, solving problems of others, we just continue kind of to reproduce the problem of a global health power imbalances. And, the question becomes in a moment like the Ebola outbreak in Uganda, where it's like, Uganda needs our help. Are there other ways of thinking about that dynamic? How do we get around this kind of history and this kind of embedded mode of practice that global health carries with it? So what I want to kind of walk through in the next, I guess, half an hour or so is just Ebola outbreak as a kind of case study in this problem of framing, right? So like, what kind of problem is Ebola? And I want to talk through kind of the moments where Ebola shifts from becoming, a public health issue like something that is at issue in a place, for a country, to becoming a humanitarian crisis and a biosecurity threat, and how those different kinds of frames of what kind of problem this is create a different set of actors, resources, practices to deal with this problem. And in that, going back to Farmer, how is equity or justice, how does it get occluded by that kind of framing? And I'm going to kind of move in three parts. Apologies. Is start with how did it become an emergency? What were the tools through which, Ebola as a kind of, problem of transmission in a place become a global, public health emergency of international concern? And, it's interesting looking back in this post-COVID because comparatively, of course, right, Ebola is, not even in the same league in terms of deaths, in terms of transmissibility, in terms of, biosecurity threat, right? But, in this kind of moment, it inspires this kind of total public health, global health, terror and emergency. And I think it's interesting to think about, what kind of diseases carry that kind of charisma and how does it garner global health attention? And talk a little bit about how once it became an emergency, what kind of responses came on the back of calling it an emergency. And then I want to reflect a little bit about kind of the research response, which is, I think really an interesting moment of where we are right now about kind of what is the relationship between the tools that might solve the problem and who makes the tools and where are they distributed. So I just have a couple comics, which these two I find, really nicely capture this kind of what I would call, the politics of attention and neglect, right? So, I think this is very legible. We have a problem going on in Africa. This is, small, again, the fatality small, but for an Ebola outbreak at that time, like much larger than all of the previous ones on record combined. You have MSF, the kind of classic de facto responder to viral hemorrhagic fevers because they have the kind of technological capacity to do so, calling to the world saying, can you hear me? No one's paying attention to this problem. And, the assumption being why? Because it's Africa, because this is a dirty kind of disease. We're not interested. Now, the second comic also has a kind of continental representation. And I think what's so striking about this is that now all the attention is being brought to bear, right? Now it is Ebola is a problem, but the kinds of measures that are in place actually precipitate the same kinds of neglect and exacerbate the kinds of problems which they sought to solve. And I think, what's interesting to think about is how when we're calling for attention for the world, is how some forms of global health attention or how that attention is brought to bear on the problem don't actually help much for the people. There still might be these kind of key, the people who are actually suffering it might actually be still neglected within that kind of overwhelming response. So again, just kind of bearing in mind that how, that global health attention might, not always touch ground in a way that's beneficial for everyone. Now, this amazing blank slide is for everyone to take a moment and have a drink. So I'm just going to start and talk a little bit about the response. About kind of making the emergency, right? How did this disease, this West African Ebola outbreak, first become the first Ebola outbreak to be, a public health emergency of international concern? So just a kind of brief outline, taking us back now. Essentially, the story tends to begin with a kind of, search for patient zero. There was some interesting work looking at, the kind of conventional understandings that this is, it's a zoonosis and people, that this is about, a disease that's jumped from a bushmeat, from a hunter. I was involved in some interesting work looking at the role of kind of children and bats and kind of playing with animals as being a site of potential zoonotic transmission. But there's still this kind of question mark about, how did this happen? And I think what's interesting now is that Ebola outbreaks are so recurrent after this, and, that this question of the patient zero, where this started, is really obviated by the fact that it is a general hotspot. There's a hotspot of transmission of this disease, and we can expect, I think, it's been, there's been one every year, if not few months, that kind of, simmer across the region. In this case, it took, a really, for this disease, a kind of terrifying amount of time for it to be confirmed. So it was, transmission was happening over months in a forested area in Guinea. Transmission eventually, when it was confirmed, it was kind of upgraded that this is a kind of regional issue. But over the course of the summer, a kind of problem which, people felt we know how to deal with this because Ebola had tended to be constrained in rural areas. And because it's so virulent, it tends to burn itself out quite quickly. Something happened, and transmission happened in regional capitals. There was kind of riots over quarantine. There was a terrifying case in Lagos. And, MSF, you have that kind of comic at the beginning saying, we need help. And for the first time, really, because they are, I think, there's, they don't tend to call for military support. They operate, as separate from those kind of security measures, really called in support in this moment. It was quite a remarkable expression of the degree of emergency. During the early months of the autumn, the UN starts pledging money, and the WHO declares this a public health emergency of international concern. And again, just to remind us what defines a fake, and this is language, again, that I'm sure you are all quite familiar, but it's a public health emergency of international concern by definition is an extraordinary event, right, which is determined to constitute a public health risk to other states. And now what's interesting is it implies a situation, that might be very serious, but that's also quite unusual and unexpected, right? Something that for which the kind of international community is not prepared. And what made, and again, sorry about the slides, but I think just to note that Ebola really wasn't usually, is something that had been handled. It is a terrifying disease. And I think culturally, it conjures a particular kind of terror. We think about, movies like Contagion. We think about any kind of, World War Z. The kind of Ebola disease occupies a very iconic place in, I think, the popular imagination. So, but it is something that had been handleable, like it had been able to be contained. And what was extraordinary here is that, not only was it the first time in recorded knowledge that there was an Ebola case in West Africa, was that it was in a context that was much more densely populated. It was in a kind of, a 3-state border zone where there was a lot of traffic, incredibly poor. And I had a colleague of mine describe them, I think, that kind of region as being sociologically proximate, communities living very close, but politically remote because of years of civil war and really entrenched kind of post-colonial violence. There was a deep abiding distrust for the government, but most also specifically for kind of hospitals, which had been, rebel strongholds. So there was already a sense of kind of tensions between who would be the first responders in an outbreak and the kind of trust it requires to get the population to respond, and the kind of those systems. So it was a tinderbox of kind of how difficult it would be to actually contact trace and get people to follow measures that would help support their health. Now, I'm just going to pause for a minute. Am I still coming clear? And I tend to speak quickly.
All very clear and very good.
I will slow down. Sometimes I rattle. Don't hesitate if I'm not making any sense. I think what's interesting is this kind of moment, right, where there's disease, it seems, uncontrolled. They're not able to contact trace. There's this effort to say, how can we track this, what's happening? How do we produce things that we know? Any as health professionals are so important, right? Is how do we get some epidemiological knowledge on the ground of where this outbreak is progressing? And, a key issue was that the health infrastructures and the kind of, disease surveillance that might be in place was, was very radically under-resourced. So there was a sense that, even what we can tell, there's probably much more going on. And the first, epidemic and kind of modeling attempt that was published in the fall by the WHO Ebola response team said, here's our sense, but actually things are, the deaths and numbers are certainly higher, right? Because people are evading diagnosis and treatment. They haven't been included. There's those who are buried without a diagnosis. So it's this kind of, how do we understand this problem when we can't even follow it? And, not to get too granular, but I think what was so interesting in those early epidemiological efforts to model the outbreak was how they kind of accounted for this shadow epidemic, or this kind of space of non-knowledge, of ignorance about what's going on. And what's interesting is that they had numbers on kind of beds in use, and then they multiplied them by 2.5, which was just a correction factor to say, well, this is what we can see, but because of what we're assuming about people evading treatment, about all these other factors, about what we can glean, this is actually what we think the corrected number is. Now, again, for those of you who are actually infinitely more quantitatively inclined than I am, you begin to see those graphs, right? These kind of exponential. I think Margaret Chan at the time referred to it as a hockey stick graph, and people, it's almost that not just the disease, but actually the figures that you're beginning to read out carry their own terror, right? Because suddenly the epidemic becomes a feature of its own scale, right? Becomes a kind of tipping point of exponential growth. And you get to see, this was, again, you have the kind of actual numbers, and then people were projecting millions, 2.5 million cases by December, according to these modeling. You also get really evocative graphs, right? About where all these Ebola cases going. I mean, it does begin to feel, you understand the power of these kind of visualizations, because it's quite a terrifying prospect to imagine. I mean, all this being said is that, anyone who knows anything about Ebola, and there was questions at the beginning about whether this is a mutated strand, is it actually airborne, is that it is actually quite hard to catch. You have to be in contact. Generally, you have to be, it's very easy to catch if you're caring for the sick or caring for your child. If you are sitting on an airplane with someone who might have early symptoms, it's not going to spread in that kind of way. And indeed, early, just kind of early on in the new year, there was a whole bunch of kind of, calling to task the modelers, saying, there's been a huge overestimation. This shows problems in modeling, why it's less devastating, how forecasts can go wrong. And again, looking back at this material, you think about just how political those numbers became in COVID, right? And the kind of uncertainties built in, and what, modelers had to work with, which is not a lot, right? And again, sorry, this slide doesn't come through quite clear, but I was very struck by how the modelers respond to some of these questions. Martin Meltzer at CDC said, we were telling policymakers that if we don't do this, this will happen. Accuracy for the sake of accuracy is merely interesting, and interesting is not good enough. Neil Ferguson, who became an incredibly important figure in COVID in the UK, one of their purposes, the models, was to wake up the world and say that this could be really bad if we don't do anything. The result was a series of warnings that altered the world. And Chris Whitty, who is our current chief medical advisor medical officer in the UK, models showed us what we needed to do. They made us move. And, I think that's such a profound way of thinking about modeling, as something that is a mover, right? That models do this work. They're not accurate for the sake of accuracy, but they produce a response, right? So what was that response? Sorry, that says response. it was a lot of terror, right? This kind of sense that 2.5 million cases, that there is Ebola coming to the US. And I mean, just in a kind of, to give some context at this moment in the US, it was the midterm elections, right? And this is Obama was president, and there was a lot of entangling between the problem that Ebola posed to America and the kind of opening up of our borders to terrorists. And you can see again, and this is, very social science head on, how this discourse of framing Ebola as the ISIS of biological agents produces a kind of sense that this is not, I'm the kind of people who are coming into the country with Ebola are not kind of, objects of care or empathy or concern. They are, they are terrorists coming to poison us at our borders. And, language you see in these moments, language does matter because it ignites a certain kind of response and understanding of what the problem is and how do we face it. So, going back to those kind of first days when the WHO is calling it a fake, the extreme anxiety of what this Ebola outbreak presented, I mean, brought together what was I think, the first unanimous since World War II vote for UN Security Council support for the Ebola emergency response. And the rationale, because the UN Security Council is not, it's WHO who's usually involved in that kind of responses, was that, the Ebola outbreak is undermining the stability of most affected countries, and unless contained may lead to further instances of civil unrest, social tensions, and a deterioration of the political and security climate. Now, it was incredibly important to get resources on the ground, but you see Ebola shifting again from this kind of problem of kind of public health to one of civil unrest, right? That this is actually an destabilizing force. And, one can ask, like, what was, in terms of, getting, money on the ground, kind of global health attention, this was an important step, right? But what kinds of responses and ideas did this precipitate? I mean, you had, and again, you see this in COVID. I mean, you had the kind of incredible lockdown of populations, right? So you need border surveillance, transit restrictions, like quarantine. That if it's a biosecurity problem, our first issue is not further spread across borders. Also, in an emergency, and again, we've all lived through this, that this becomes a space of exception, right? You can justify expressions of sovereign state power, at the expense of human rights, because there is a public health emergency to be contested. The other, piece of this that's, was striking, especially from kind of the space as an anthropologist, was how communities and community resistance, the question of kind of all of that shadow epidemic, also became like going back to Paul Farmer, the cause, right? How we frame the cause. Well, Ebola is the agent, but the cause of this kind of onward spread in the epidemic is this kind of, these rogue populations, forms of community resistance, expressions of violence, and my favorite, deep-seated beliefs and cultural practices, right? So, this is Margaret Chan, former WHO, says, deep-seated beliefs and cultural practices are a significant cause of further spread and a significant barrier to rapid and effective containment. And there's no simpler way to say this is, culture is the cause, right? Now, opportunistically, what was interesting is that once culture is the cause, they actually want to talk to anthropologists, which is not always assumed that anthropologists are anyone you want to talk to in global health for any reason. But in this case, because there was seen to be this kind of basket of exotic practices of, bushmeat, of weird burials, of, people going to traditional healers, that, in this kind of space of total emergency, we needed some idea of what these quote unquote deep-seated cultural beliefs were. And I was involved with a group of colleagues who set up an Ebola anthropology response platform to try to talk through and give some insight that would hopefully kind of attenuate this idea that, culture is, these people are the, the purveyors of the disease. These are the problems, and this is what we need to kind of squash down to change. I did some work in this time also because I had come to Ebola through Lassa fever. I was doing some work around interactions with rats and where are the kind of points of transmission in domestic space. And we were very interested, myself and colleagues at LSHTM and at Durham, understanding what happened around this question of bushmeat, which is a problematic term to begin with. But we did some interviews during the outbreak about kind of what happened when the first kind of step, and again, I think this speaks to the sense of cultural disgust, was to put a bushmeat ban on in the region. Now, anyone again who knows anything about the disease, Ebola is seeded by not an outbreak like that by one, unfortunate bat or monkey meeting one unfortunate person. So if you lock down on bushmeat, that's actually not going to help the outbreak as it's going on now. I mean, what needs to happen is human to human transmission, right? Which requires care, contact tracing, a population that's willing to be traced. So the immediate step to introduce a bushmeat ban just completely set the tone. People found this. It didn't make sense. The quote on the bottom I've put up there was from a farmer who describes, look, they told us not to eat monkeys because they're sick, but I tried that and actually I'm eating them and I'm fine. So there's the sense of there's the irrationality in what the messaging is and people's lived experience. Then there's the kind of exacerbation of mistrust. And I think what was interesting in this quote on the top, it says, there was a law passed by these MSF people. I mean, of course, MSF didn't pass a law, but there's this conflation between these international responders and incredibly impactful, and devastating for a lot of people who are now in quarantine and just can't even get meat on their lives. And now it's, now you've kind of entrenched this sense that here is messaging that doesn't make sense. Is this about, this is about genocide. This is about kind of political maneuvering. There's all this money coming in, and it becomes this incredibly complex set of political suspicions. And again, looking back at this on COVID, it's funny because I think, how similar, right? How quickly vaccines were, lockdowns, everything was politicized in COVID along similar lines. But the way this, there's some, ironic justice there, because the way this was portrayed was like, very, misinformed populations, uneducated people coming up with rumors, when in fact, the same set of kind of community distrust played out all across Europe, across the US, across the world in the years to come. And just a kind of couple points on this, and this is kind of where the kind of what anthropologists or social scientists, try to do in these kind of moments where, it is an emergency, one has to contact trace, is to kind of reset how we think about the, community resistance. One kind of key point is that we can tell people all the risks of something, but we might not, even if we know the risks, prioritize them, right? So, I always thought of this as, if you're told, yeah, don't hold your child, he's going to make you sick, it's my child. I might do that anyway, regardless of the risks. That traditions, also perform incredibly important social and political functions. So if you have a burial that's, conducted in the wrong way, the spiritual repercussions on that might be worse than the potential risks that you incur from infection. And, a key piece for regions like this too is that biomedical expertise is not a given, right? People say, go to the hospital, like don't go to traditional healers. But if you have had an entire experience of going to hospitals where there's no resources, where you are neglected, of course, you're going to go to someone in the community that you trust. And, it's not some deep cultural seated beliefs that does that. I feel if my experience had been bad at the hospital here in Oxford, I might go find a doula who I feel more comfortable with if I needed to give birth. And finally, that public health messaging is shaped by history, by who's delivering the message. And, again, you need look no further than kind of Trump, Biden, who's speaking the message to see how is that going to be received by, the population you're trying to convince to do, to protect themselves. So again, just a couple kind of headlines from experience in the response was that, ultimately local initiative when you're dealing with an infectious disease and contact tracing is just as important. I mean, really, than like all of the millions, brought to bear. I stand by that because in the end, what you need, and there were plenty of examples of, tiny rural villages that did this, is safe practice, contact tracing. I mean, of course, you need clinical care for patients, but in terms of kind of outbreak control, it's the people who are being exposed that you need to kind of convince to support that. And the other point is that deep-seated cultural beliefs is a complete inappropriate way about thinking about culture, right? Cultures are not totally fixed. They can be adapted. And there's, with some very moving examples of having dignified, culturally appropriate burials that also manage to compromise to be biosecure and safe. And to do that required, bringing, instead of othering people, traditional healers, and then bringing those people on board to talk through what that might look like. Now, my last couple comments here, just kind of where, there was this kind of response, the public health response, but the kind of other exceptional, and I think what's important about the kind of the West African Ebola case as a case study in global health is that it really laid the tracks for the kind of accelerated experimental development of medical countermeasures that became so important in COVID, right? I mean, COVID, the vaccines, I mean, the idea that you could sequence a virus and then within months have shots in arms, I mean, this is, incredible. But that kind of, possibility really gets its roots in the Ebola outbreak response, because what you had is the first moment where you have an emergency, a crisis, a humanitarian crisis, and the tools and justifications to actually run experimental trials in that setting, which is quite remarkable. This is from this guidance for ethical conduct that was released during the context of the outbreak. And, again, just to pause a moment on the justification here. So infectious disease outbreaks are periods of great uncertainty. Research is an integral part of the public health response. We have to learn as we're going. In the current exceptional circumstances of the West African Ebola outbreak, researchers have a moral duty to evaluate these interventions in clinical trials that are of the best possible design. And this is, I think, quite remarkable to move from, can we do randomized, blinded clinical trials with people in an emergency setting, but it is a moral duty to evaluate these interventions. And I think that is worth underlining as a kind of major shift in how, global health response is imagined. So how did this become an imperative? Well, we talked about the epidemiological projections, that this was a catastrophe in the waiting. There were candidates. I mean, they were very early stages of development, but they had been developed as part of the, in the US, as part of the September 11th kind of biodefense agenda, which had listed Ebola as a possible biosecurity agent, right? So again, you see this interesting place that Ebola occupies as a very neglected disease on one hand for the people who suffer it, but also this incredibly agent, category A biosecurity threat for which, some investments will go in and producing countermeasures. It's a kind of argument that's saying, look, it's so deadly that people should have this kind of right to try, right? They have no other options. We should be able, there should be this kind of, even if it's experimental and unknown, there is a humanitarian obligation to expand the access to these countermeasures. But what really kind of tipped the balance in these arguments, there was incredibly, upsetting death of Dr. Sheikh Umar Khan, who is Sierra Leone's national expert. And he was really, this leading figure in the response and in viral hemorrhagic fevers, the regional expert. And he got contracted Ebola, and there was a debate with MSF about whether he should have access to ZMapp and some of these experimental drugs for which, MSF and, other kind of, humanitarian agents who had been, extracted and brought to the US and had access to, whether he should have access. And it was decided no, these are experimental products, and he died. And I think people immediately realized the imbalances of having, people medevaced, white Americans having all kinds of everything in the kitchen sink thrown at their disease to improve their status, and then just this incredibly important frontline researcher allowed to die. So you get a kind of moral framework that makes the case that these new experimental products are going to be given access to. And what's quite interesting here is that there's also another kind of experimental kind of an imperative, and the imperative is that the numbers, as we've seen, were not massive. It wasn't COVID. There weren't a million people that you could be trial these things on, but the disease was actually becoming controlled. So there was this, in early January, there was this sense of the window of opportunity is closing. We have these vaccines, but we can't test them. And we need to roll these out. If not only, interestingly, kind of less that they might help end this outbreak, which already looked like it was going down, but that if we're going to have these vaccines for future outbreaks or for future problems, we're going to need to test them. Otherwise, we're not going to have the data. Now, I won't go into too much detail here. And again, sorry about the slide, but basically, I think there was a really interesting effort led by the WHO to square what would be a public health response in an emergency with a clinical trial. And essentially, they did a kind of cluster randomized design where they would follow, and it was amazingly in the model of ring vaccination, which had been so hugely important for smallpox, where you would vaccinate around a case. And they staggered the time at which, one ring would get it immediately, one would get it a few weeks later, and had, very compelling results on this Merck vaccine. But as it's now become a very important, the kind of strategy in ensuring expanded access to products in emergency outbreaks and following subsequent Ebola outbreaks, and elsewhere, is to think, well, how can we make a clinical, an experimental trial? How can we generate data, but also justify that experimentation as part of a public health response? And the ring vaccination was really important to that. Now, that's not to say there hasn't been it has been fraught how to think about this, this now integrating an experimental framework and investigations into humanitarian response. And, sat in meetings where, the MSF is saying, you have this experimental protocol to generate data around these vaccines, but we just need them. We need to give them out. And I like this phrase, that there's this, it's incredibly rigid system that's hard to understand. We don't understand why we just can't see, people and vaccinate them. And Nellie Roberts says, it's like giving firefighters a bucket of water to put out a fire, but only allowing them 1 cup of water a day. So again, this kind of, it is not an easy alliance, emergency response with this kind of, with a relationship with commercial entities that are going to need strong, robust results in order to get their products licensed. And, over the past almost decade now, I think there's been a really interesting kind of way of how do we justify and think about the needs of the market, the global health market, to actually have the incentives for companies like Merck or Janssen to, put in funding to run these trials. It's not like COVID, right? It's not automatic that there's going to be massive profits for something like this, and yet also kind of deal with the needs of populations who need an immediate response. And, just a couple last points on this. I think what's interesting, and I do, it is the case that there are going to be continual rolling outbreaks, is that you do have, for the first time, really since the West African outbreak, and now in North Kivu and DRC, a huge population of survivors. And the epidemiological insights as to how infective survivors are, what is, the kind of how much viral load they still carry on in their semen or other bodily fluids it's unclear. But there have been a couple outbreaks that have, traced back to the partners of survivors. And this, whether or not, this is a public health concern, it creates an interesting opportunity, really, for companies to think about, okay, if I'm going to invest in more vaccine production, where can I see if there's hotspots? Is there an argument for a prophylactic and not just reactive approach to vaccination? And again, this is all getting meted out, but I think it's interesting as a case to watch how global health research and innovation has to kind of ask these questions about what is the right policy and what is the, how do we ensure that there are demand signals in order to get companies to invest? Now, the other kind of interesting conversation, and that's come out of this, and it's also really come out since COVID, is, well, instead of always scrambling to get big companies to invest, in this problem of market failure, why doesn't Africa manufacture its own vaccines, right? Why don't we solve that problem and rethink where in the world innovation is driven? And that, comes back to this question of decolonizing global health is, maybe the issue is not just allocation of resources, like they need more masks, but why aren't we investing in masks being produced, in Africa? And one of the final interesting points that came out, I think, of COVID, in 2016, Ebola prompted also the organization of the African CDC, because it was that kind of Ebola response that actually helped create the conditions to really build, to say there should be some kind of regional capacity to respond to outbreaks. Now, in the context of COVID, where again, the question of supply chains, of kind of the movement and allocation and how inequitable that was, we have organizations like CEPI asking to kind of set up new, not just, promises to deliver, a fair allocation of vaccines, but how do we build that manufacturing capacity on site? And, I want to end with just a quote here from John Nicholson, who is, was the founding director of the CDC, but is now moved over to run the US global AIDS response, and is a key kind of global health security diplomat. Said, trusted partnership will be critical in advancing the vaccine manufacturing agenda on the continent. The partnership with CEPI symbolizes cooperation and collaboration to help respond to infectious disease threats and ensure Africa's security. Given the impact of COVID-19 on lives and livelihoods, now is the time to ensure that existing community commitments are translated into concrete actions towards a new public health order for Africa. And what I think is kind of and then this is where I want to end, an inspiring moment to think about is to say, all right, if we need to change how, what global health, how it works and what it does and the kind of problems it frames, maybe there's, a question of the new, what does the new public order look like? Well, it looks like a vastly more distributed model of response and those capacities. And, I think a lot of interesting questions are now being raised about where, what equity and justice would look like if it wasn't always a matter of the proper kind of distribution of tools from the north to the south. And I'm going to end there. I'm sorry, I was racing through a little bit. I saw that we were running out of time.
Thank you so much. Thank you so much, and this is really interesting. I think thanks for this really, important presentation that I think touches on many questions that I think we in epidemiology and public health deal with, but that people who are in the public health and epidemiology world do not always think about so carefully, such as the role of culture. So I think this is super interesting. Just wanted to open it for a couple of questions. If anyone wanted to just jump in and ask a question. Not so sure where you see the hands in this application, but perhaps people can just jump in if they have a question.
If there are no questions, perhaps I can
go ahead,
ask
Andrea.
one.
Yeah.
So I'm Nolwenn Buller, also an anthropologist, and thank you for this wonderful talk. It was really a pleasure to listen to you, and I think it's just a pity that more colleagues from other departments perhaps they didn't know the information or something that perhaps because I think it's really interesting. And one of my questions, because one of my projects here in Unisanté is on the COVID pandemic, and you mentioned several times that there was the same actors involved and the same. It struck me also how the narrative is similar between the two outbreak. But could you tell us a little bit more about the connection between Ebola and COVID, or the parallel you can draw?
Yes.
Yeah.
No, thank you so much for the question. And it's lovely to know that there are anthropologists working working on COVID, because I think one thing, I mean, and this is more to the difference, is it was interesting how quickly in the context of Ebola, anthropologists were brought to the table because of the nature of the disease, and how with COVID, no one no one at least came knocking on our doors, because this was a disease with a very different trajectory. I mean, I think what's was very interesting about just thinking, first with the WHO, because WHO was a very important, first as a failed actor for Ebola. They didn't respond quickly enough, but then kind of rebirthed itself as this great runner of trials. And I think, the legacy with WHO, you have the R&D blueprint, you have a very big kind of research agenda for that organization, which I think is an interesting evolution. But for COVID, it was more, I mean, it was interesting how that kind of its role was sidelined because there were so many, big governments investing huge amounts of money. So it was almost curatorial, right? They had the kind of recovery trial. We're going to put data up. We're going to, try to do, equitable distribution. But my sense, and I might be reading this wrong, is it wasn't hugely successful in being able to leverage, companies to do that, to actually begin to distribute. But I think, those dynamics of who produces solidarity, who are the important institutions for doing that, I think in both cases, became an important question, because it was clear everything became so politicized so quickly. So that, you needed some broader conversation about what is the nature of cooperation when the problem is crossing borders. I would love to see what you're working on. You have to email me. It's very important. I think not enough anthropologists are involved.
Yes, and that would be a related question. Did you see, I mean, did it change the COVID? You said, yeah, anthropologists was not involved as much as in Ebola case, but did you see opening, or how do you think this relation between anthropology and public health are reconfiguring now at the moment? How do you see an evolution, or how do you see that?
Yeah, that's such a good question. I mean, I think, I think once, the issues around the vaccine hesitancy, the politics of vaccines, I think, was this kind of, you did get this gradual recognition that, rumors, community resistance is not just something that happens in Africa, right? And that, in fact, a lot more attention needs to be given to how, not just what are the measures, the countermeasures, but how are those measures communicated? How are people understanding their own risk? And I think there's been some really interesting work that has brought attention to the different ways people weigh up their health making decisions, right? Because, people don't act on information in the same way. I mean, what I also hope, and, to speak, selfishly, where, I hope anthropologists and that kind of granular attention could be given is to this question of how do we rethink, global health R&D? Where is this? What does vaccine transfer look like? Who's involved? Who are the? I mean, questions like procurement and supply chains. I mean, these things became so, front of mind during COVID because the global economy all of a sudden seems so fragile. And I think anthropologists have a lot to possibly say to that. I mean, I don't know if people believe that we do, but I think we do.
No, I agree. Yeah, thank you.
Thank you very much for that. I think we this was a little bit. I know we are now a little bit out of time, but I think it's okay to if you don't mind, to stay for a little while. Was there another question?
In the chat, there is one, I think.
In the chat, okay.
If you want to. And Niels, a colleague who's also an anthropologist, is there.
Yes.
Okay, so then this is Kara's question now. You mentioned something that sounds like when a pandemic is linked to culture, then anthropologists are involved. However, whether in all epidemics a cultural dimension?
Yeah, I mean, I think, yes, and yes, right? I think, what I worry about, and I know anthropology, I feel just on this group will agree, is when culture gets circumscribed to a very specific set of practices, right? Like it's very easy to see culture in burials, right? Or it's very easy to see culture in traditional healers, but harder to see culture in the hierarchies of how, MSF practitioners work in an ETU, right? And, there's a lot of culture in that. And I think, keeping that kind of symmetry involved in terms of where analysis goes is, a very basic point, but one I think in the middle of an emergency is so hard to make that point because it's about speed. We need to do this, we need protocols, we need to move. But I think, it's at least with Ebola, it was very clear that actually the time to really look closely at how we were moving really would have forestalled a lot of really bad outcomes early because there was a lot of distrust, there was a lot of miscommunication, and I think that just seeded a real problem.
Thank you. Perhaps one last question, if anyone wants to jump in.
I can jump in. Just a small question. Thank you very much for your presentation. Really interesting. And as I'm working on cancer in both Switzerland and Latin America, I was wondering to which extent in your research you have been dealing regarding Ebola with the question of epidemiological transitions and the whole perhaps new regime or emerging regime of global health focusing on chronic diseases, non-communicable diseases, and how it has shaped the Ebola response. And perhaps now, because you said that there was this interest in the survivors, and if it's not a signs of an interest for the chronic forms of Ebola to a certain extent, as there is also a trend with the long COVID.
Oh, that's so interesting because it's true. I think, and this, I was listening to an interview with John Neckensong just before I came on, and the framing of the African CDC is still, it's very much infectious diseases, right? Which is, is that legacy, I think, of the kind of tropical medicine, colonial medicine. But it's clear that that kind of preparedness agenda, outbreak agenda is deeply problematic when you're dealing with, the kinds of diseases like, cancer, which are, completely underlying and laying over any expressions of kind of, health problems. I think the question of, what happens when a disease, and this is also what's quite interesting about Ebola and the question of how you frame it, goes from being a kind of super infector, transmission problem to a sexually transmitted disease, right? There's this question of, how do we handle this as a sexually transmitted disease to a chronic problem? People with, losing their eyesight, constantly debilitated, and, what kind of resources are best placed for each one of those problems. I think, now we know Uganda is very good at responding to the outbreak bits. But just looking back at Sierra Leone, there was a whole cohort of Ebola survivors who were promised free healthcare from the States, and now that's not happening anymore. And I think, that you get these multiple Ebolas, right? And one of those Ebolas is totally now neglected. So, I mean, I think again, going back to the question of what anthropologists can do, I think, returning to the, let's move our bucket out of just the constant, strange outbreak phenomenon and actually look at the chronicity is the important move to make. So good for you. You're doing a good thing.
Okay, thank you so much. I think we can release you all and Anne for lunch
Thank
now.
you.
But thank you, Anne. This was a really exciting presentation. Thank you, everyone, for coming. And I think we hope that Anne Kelly, who is in sabbatical this year, I hope she'll visit us sometime when you come to the WS show, and we'll have some more time for one-to-one meetings.
Yes, absolutely. I would love that. And apologies for the silly technical issues at the start. And it's just been such a pleasure. I was grateful for the prompt. Thank you, everyone.
Thank you so much, and thanks everyone, and see you next time.